Dear colleagues, dear students, dear interested participants, welcome to the MOOC on an introduction to cone beam computed tomography. Cone beam computed tomography is a quite modern and recent technology in dental medicine. It's actually about 15 to 20 years old and has been introduced in the year 2000 into our field. It's actually based off a rotating gantry which has an X-ray source on one side and a detector on the other side. You will see it on this slide here. First looking at it, it seems to be quite similar to a panoramic view, but it has other features, as you will learn now. During this rotation, the field of interest or the region of interest is at the center, fixed at the center, and the gantry is rotating around that. During this rotation, normally around 500 to up to 1,000 images are taken. So a lot of images. Those are called basis images, and they will be very important later on. The imaging can be performed in a sitting, in a standing, or also in a supine position, depending on the device. That's not relevant for the quality, but it's dependent on the device we use. I'll give you an example here in the following. This is an Aquitomo device. Here you sit, and you also see the rotating gantry, which is rotating around the head. The head is the center of interest. What is different from a medical computed tomography to a dental cone beam computed tomography? The cone beam, as you see on the image on the left, enables us to take an image with one rotation, which is in contrast to CT imaging, where the slice or the fan beam actually leaves us to take an image of a head by doing a lot or multiple rotations. If you go back to the core of a CBCT, the core of the image actually, that's a voxel. The voxel can be of different sizes. They can be about 0.08 to about 0.1 millimeters, a bit larger. And those together, they composite an image. And this image is normally a cylinder. And we also have spherical volumes, but normally we use cylindrical volumes. As you see here, those cylindrical volumes can be small on the left, they can be in a medium range, but they also can be in a large or maxillofacial range. But all those volumes are here to depict different areas of interest within the maxillofacial region. An alveolar range of about a few teeth, or the maxilla and the mandible if we talk about maxillofacial surgical approaches. Just to give you a little bit more visualization of those cylinders, I have here put some glass cylinders which depict typical cylindrical volumes used for CBCT imaging. They range here in this image from 4 by 4 on the far right down to 10 by 10, which is quite a large field of view on the far left upper right. Well, now we have those basis images. What do we do with those basis images? We need those in the computer to calculate a volume that we can look at. So this takes time, and this depends on variables such as hardware, software, but also on other issues. Normally it doesn't take very long, it's a couple of minutes, and it will surely be more fast in the future. And then when we have actually computerized these basis images into basis projections, then we can look at those. And those are normally axial, sagittal, and coronal cuts of the region that we screened. So just to give you an example here, we have on the left a sagittal, on the middle a coronal, and on the right an axial cut. We can also look and diagnose image data sets on multiplanar reformatations. These are actually virtual slices we cut into the maxilla or into the mandible, and then we have cuts, actually coronal cuts, along this axis that we draw, which is a little bit similar to elderly CT prints that we used before all was digital. And last but not least, we can also produce 3D volume data sets. Surface rendered images, volume rendered images, which are good for presenting those data sets to our patients, but might also be helpful when we process images for example, surgical purposes. We have one problem at hand. CBCT is not perfect, and one of the biggest problems is actually artifacts. Some artifacts are acquisition artifacts. That means physical properties make that these artifacts are actually visible in our images. Typically we see cupping, beam hardening and scattering. And specifically when you have metallic objects, it can become quite difficult to actually diagnose an image. But we have also patient-related artifacts, and that's because patients move. As you have seen from the example I've given you of a sitting CBCT device, our patients are actually awake and they move. And when they move, we can have slight artifacts like you see on the right. Often these are double cortical projections, but they can also be as severe as seen on the right here, and they can be so severe that actually a CBCT image cannot be used for further diagnostics. With this short introduction, I hope you have gained some insight in this exciting novel technology of three-dimensional imaging, and I hope you're still interested in learning more. Thank you very much for your interest.